Welcome back to the Don't Miss a Beat YouTube channel. Today we are going to talk about what is a right heart cath. I know there's already some hemodynamic lectures on here that you can watch. We are really going to focus on today is the basis of a right heart cath. What is it for? What are the access options? How is it different from a left heart cath? And then go into thermodilution injections and how that works. On the right hand side is the Swan Ganz catheter. If you work bedside, you might see this. We're going to take a different perspective in the cath lab because we actively move it to get pressures and use it for some other things versus it just being an indwelling catheter. But definitely tune in. There's always something that you can learn. So first of all, a right heart cath. Just some different components of it. Number one, it is a venous access. So the right side of your heart contains the deoxygenated blood and it's bringing all of that blood to the lungs. So that does come from the veins. You have some different access options. Femoral vein and the IJ, the internal jugular vein, are very common. Right or left, it doesn't matter, whichever one is patent. Sometimes people have occluded IJs or dialysis catheters there, so then you couldn't use that and you would have to use a femoral vein. Alternatively, brachial vein is another access that's becoming more common simply for the fact because we do radial access now for the left heart cath. So if someone's getting a right and a left heart cath, we might go right radial artery, and then we would go in the right arm and use the brachial vein. Sometimes we'll call in the PIC team and have them have a line already. We'll exchange that line out for our sheath to be able to use for our catheter, and then they would have to have another type of IV access for medication. The last one I put on here, because it's in a lot of text, is the subclavian vein. Now that's a harder access. It's right subclavicular. It's more difficult to get hemostasis there, so not super common. These are going to kind of be your top three, but you will see this in some books as an option for access. For the right heart cath, we use to get right heart pressures. Okay, pressures on the right side of the heart. We can go chamber by chamber and get those. That would include the right atrium, the right ventricle, the pulmonary artery pressure, and then what we call pulmonary wedge pressure we get from the right side, but it actually represents the left atrium. And the reason for that is between the, and I'll show you what the wedge position is. So if we're wedging in the distal pulmonary artery, between the pulmonary artery, the lungs, and the left atrium, there is not a valve. So if you notice, like between the right atrium and right ventricle, there's a tricuspid valve. Between the right ventricle and the pulmonary artery, there's the pulmonary valve. Valves create, in a way, gradients. That's how they open and close. Now, because there is no valve between the pulmonary artery and the left atrium, in theory, if there's absolutely no disease present, a wedge pressure should represent your left atrial pressure. It is difficult to get a left atrial pressure without going direct, like a transeptal puncture, something like that. I'll show you that from the left heart cath side of things. But it does give us a lot of information when we're assessing the right side, not just of pulmonary disease, if there's any presence or congestion there, but also if there's any issue with the mitral valve. It's kind of nice that we can get that from the right side. Now, there are some risks of wedging, so not all physicians choose to wedge to get a pulmonary wedge pressure. Sometimes you physically can't, which we will talk about as well. Now, while we're in here, the other information we can get are pressures, which we talked about. Saturation, so the percent of oxygen in the blood. Remember, this is the deoxygenated side of the heart. However, if there is a shunt of some kind, so oxygenated blood from, let's say, the left ventricle coming into the right ventricle, or from the left atrium coming into the right atrium, we're going to see some abnormal saturations. Same thing if the patient has, let's say, a PE, okay, a pulmonary embolism. They're going to have a low saturations in their pulmonary artery. We can pick those things up. And then with those saturations, we can actually calculate cardiac output, or you can use a TD Swan, which I'll show you, and we can measure cardiac output that way, which is how long it takes from the blood to get from the right atrium all the way out to the lungs in the pulmonary artery. Now, on the opposite side of things is a left heart cath. A patient might have both, but sometimes we will only do a right heart and not a left heart. Sometimes we will do a left heart and not a right heart. But this is important to understand if your patient has had both, because you know your venous access was going to be for the right heart cath, and then your arterial access was going to be for the left heart cath. Now that could be femoral artery, again, right or left, radial artery, again, right or left, and now we even have more choices, proximal or distal. So proximal access is going to be the more traditional one. Sorry, I'm counting fingers. Up here on the well, inside aspect of the wrist. Distal, if you put your hand in a fist, let me try to draw a fist here with this really not great thing, is going to be over here. If you were kind of clasping your fist together, it would be back here, which is on the top aspect of the wrist. It's still the radial, but it's just a distal radial instead of proximal. And then you have the ulnar artery, which is on the opposite side near the pinky. So radial will be over here by the thumb, ulnar will be over here by the pinky, and again, that could be right or left hand. We're going to get left heart pressures. So you have the left ventricle and the aorta. Remember, nothing in the left atrium because it's really hard if we're putting our, let me actually draw this so it stays. Okay, if our catheter comes this way and into the left ventricle, we can get LV pressure, we can get AO pressure. The atrium is kind of back here, and that's really difficult for us to get and cross a catheter into. You can if you really tried, but it's definitely not suggested. The other way would be from a venous access and a transeptal puncture if we're in the right atrium to go over into the left atrium, and that's way more invasive than it needs to be, so we will not do that. But again, we would get that from the pulmonary wedge pressure if we're doing a right heart cath, or we can kind of estimate it based off of the LV-EDP from the left ventricle, but that's a little more advanced. We won't jump too far into that now. So the two main pressures we're going to look at are LV and AO. The other things we can get besides pressures and saturations, anywhere you are in the body, you can pull a blood saturation from. We actually have to get a saturation from the aorta, from an arterial access, to do the Fick cardiac output formulas. So if your patient was only having a right heart cath, only had a venous access, you don't want to just stick the artery just to get a saturation. Some people will estimate it off the SpO2 probe, the pulse oximetry. That's not really accurate. So alternatively, they'll do the thermodilution cardiac outputs on the right, so you don't have to use saturations. We'll also take pictures. So we're going to do coronary angiography and left ventriculography, or an LV gram, to look at the coronary arteries and the left ventricle. Now, can you do pictures for a right heart cath? Yes. If we are doing one like for a PE, pulmonary embolism, to remove that thrombus, we might take well, I guess it's a venogram of the pulmonary arteries. In pediatrics, some patients are getting treatment for pulmonary stenosis because it's usually congenital. They could take pictures of the valve from the right ventricle and inject there. Now, when would a patient have a right heart cath? Usually if they have symptoms or a history of dyspnea, so shortness of breath on exertion, valvular disease, not just right-sided valves, but also left-sided valves, because it can back up and cause a right-sided issue. Intracardiac shunts, so those holes in the heart that we talked about, if they have a PFO or an ASD in the atrium, or a VSD in the ventricle, or a PDA between the aorta and the pulmonary artery. Pulmonary hypertension, so that is a pulmonary condition where the PA pressure is abnormally high, like systemic hypertension for high blood pressure, but on the other side. Pulmonary edema, you can put pulmonary embolism in there as well. Left ventricular dysfunction with suspicion of causation by a right-sided condition. So actually a lot of left ventricular issues, a lot of left-sided heart failure is caused by right-sided heart failure, and it's one of the harder things to diagnose because you'd really only pick that up if you were doing a right heart cath and started to see these issues precipitate on the right side. Just some other things I like to add in here: elevated BNP, so brain natriuretic peptide. It is released by the ventricles when the myocytes are under stress. So that could be from stretch or dilation. That's usually a good sign of right-sided heart failure. If they can't lay flat when you bring them into the procedure room, so maybe your patient came for a left heart cath, you go to lay them flat on the table and they immediately sit up and like, oh my gosh, I can't do that, I feel like I'm drowning. That's a really good sign of right-sided heart failure as well. That could be an indication to add a right heart cath into their procedure. Unexplained difficulty exercising or walking. So a common complaint is, I can't walk up the stairs or walk to the mailbox without having to catch my breath. That's another really good sign of needing to investigate something a little further. Relative contraindications. When would, in certain situations, a right heart cath be avoided? Now, we say relative because sometimes, even though there is a risk there, the benefits outweigh the risk, and it might be a reason why we're doing the right heart cath to get additional information. So prosthetic tricuspid or pulmonic valve. Remember, I told you we might be doing this for valvular issues. they could have a surgical valve that is failing, but having this there, if it's functioning and there's nothing wrong with it, right? You don't really have that indication from an echo there's something wrong. It's not worth crossing through with our catheters and messing up the leaflets. Coagulopathy, so you do have bleeding risk here. It is venous, so there's a little less of that risk, but a bleeding risk nonetheless, because you can cause injury to the pulmonary artery and RV. Severe thrombocytopenia, because we are putting equipment in the patient, so they will have that immune response. We don't anticoagulate for right heart caths, for diagnostic right heart cath, so that's something to consider. Ventricular arrhythmias, because anytime we are putting equipment inside of the heart, especially in the ventricles, we can cause PVCs. And if they already have underlying issues with ventricular arrhythmias, then we could trigger that response. Left bundle branch block, so that's interesting. Well, if you have, let's just draw a little bit of the conduction system here. All right, so this is the SA node, the AV node, the bundle of His is here. If you already have a left bundle branch block, then you put a Swan or a catheter or a wire in the right ventricle, and it irritates the right bundle branch. And when you kind of knock into cells that are responsible for that conduction and you, let's say, stun them for a second, and then you initiate a right bundle branch block. Well, a right bundle branch block plus a left bundle branch block equals complete heart block, right? Or third degree heart block, and we don't want that. So sometimes, for instance, on the opposite side of things, when we're doing a left heart cath, if a patient has a right bundle branch block, we might put in a temp pacer just in case we initiate another bundle branch on the other side. Again, something to consider and look out for, and it might not be worth it to do. Endocardial pacemaker. Now, these are your, well, not always heart failure patients. Sometimes it could be an ICD for ventricular arrhythmia, but let's say this is a heart failure patient. Those heart failure patients are probably going to need a right heart cath, right? We need to, especially if they're on milrinone or some of those other medications, we need to be able to trend some things, or they might now qualify for certain therapies they didn't before, and we might be assessing their progress. So take this a little bit with a grain of salt. Now, remember, if you have those wires in the atrium ventricle and we are being aggressive with our Swan Ganz catheter, it can displace those leads, which we don't want to happen. You always want to let a physician know, if they don't already know the patient has a pacemaker and they're there for right heart cath, hey, and let them make the decision on if we are going to proceed or not. But a newer lead, especially that hasn't endothelialized yet, is going to be more at risk. One that's fully healed might be a little different, but let's say they got that pacer in the same admission, that is going to be something you're going to want to bring up. Complications. Now, what can happen? Two different things going on. Number one, we have the access related issues, and then we have the catheter itself and things related to the catheter. So pneumothorax, hemothorax, those are mostly going to be from IJ access, which is why we use ultrasound and micropuncture for that. You also have the carotid right there. That's something to consider. Sepsis, that's any type of invasive procedure, you have a risk of that. And then the catheter. RV perforation. The RV is actually the easiest chamber in the heart to perforate because it's relatively thin. Pulmonary rupture, that is from overwedging, which we'll talk about. Same with pulmonary infarction. Air embolism, for a couple of reasons. Number one, we have a balloon, so if we inflate that balloon and nobody checked it at the table and there was a leak in it, then you could embolize that air. Now, this is the venous system, so it's not as risky as it is on the arterial side for left heart cath, but something we don't want to do regardless. And of course, thrombus, because we're using catheters and it can coagulate. And in general, arrhythmias. We are working on the right side of the heart, which is responsible and the location of a lot of the conduction system, so you are going to have that risk as well. Up next, let's talk about the different types of equipment we use. So first off, you have what I think a lot of people know it as is the Swan Ganz catheter. Now, that is a brand name. What this really is a pulmonary artery monitoring catheter. Some of you might hear it as a pulmonary artery wedge catheter. It's all the same thing. They are balloon tipped and they have 2 or 3 or 4 ports. It just depends, or more. Depends on what type of device you are using. Now, French size is going to matter, and this actually usually has to do with the type of access you're using. So the femoral vein is larger than the brachial vein, for instance. Now, let's just say we're going femoral or IJ, A monitoring Swan is usually 6 French. It does go down to 5 French, and I'm sure in pediatrics smaller than that. So if you're going brachial and you have a smaller access, you might use a 5 French just so you don't get so much resistance going up and over. And then the Thermodilution Swan is usually 7 French because it has more ports. It is a thicker catheter and therefore it needs a bit of a larger access. The monitoring Swan has 2. So let's just edit this one for a second. This catheter, if you got rid of this and this, that makes it a monitoring Swan. So the monitoring Swan has 2 ports, the distal port and then the balloon port, the red one. It can accommodate an 035 wire, so your normal J wire that you're used to for a left heart cath, because there are not as many ports, right? So the lumen can be a little larger in the one that accommodates the wire. The Thermodilution Swan is the one you see here. So it has 1, 2, 3 ports technically, but 4 connections of some kind. So we'll go over what each of these are, but you notice there's more stuff. So the lumen for the wire is smaller and it accommodates an 025 wire. So that is a special wire that you would have to drop because that is not a normal wire that we use. Again, you're going to want to use a J tip with both of those just to have that atraumatic tip. And this is where the wire comes out. It goes in here in the yellow and it comes out the distal end. If you notice, it will say on the package what the recommended guide wire size is. So I just took this one off a 7 French Swan Ganz and it does say an 025 inch wire, which is correct. Certain smaller French sizes don't always assume if it's a TD or if it's monitoring what it's going to take. I believe the smaller French sizes of the monitoring Swan actually use an 025 wire. So make sure that you double check that before you decide what wire you are dropping. Another important thing to note is, yes, there is a balloon here. The balloon is made of latex. So people with very severe latex allergies, you can swap it out for a latex-free Swan if you have that available in your hospital. The only thing to pay attention to when you are prepping the balloon is the latex-free Swan balloons are a little more fragile. So you want to be very careful not to overinflate those because you can pop them very easily. Now let's take a look at what each of these ports are. So let's start with the proximal port. Okay, this is on a TD Swan. So the proximal port you see is blue, and I don't know if that was the intention, but blue does indicate water, right? So that is where you're going to do your thermodilution injections that we are going to talk about. You inject about 10 cc's to get cardiac output, but you know, you might have a 12 cc syringe, waste 2, and then inject 10. It's also called the injectate port, hence where you inject. Then you have the distal port or the PA port, okay? And it's called the PA port because when this is in the proper position for thermodilutions, the tip of the catheter is in the pulmonary artery. So when you put a wire in here or inject something, it will come out here, which is in the PA at that time. And then of course it's called the distal port because this proximal port, I'll show you the markers later, it comes out at an earlier lumen, whereas if you injected in here, it would come out at the distal lumen. So this is important because you want to connect your transducer to the distal port when you're monitoring pressures, not to the proximal port. Because if the distal end of the catheter is positioned in the pulmonary artery, and then you go to accidentally and hook up to this blue one, you're going to be getting a right atrial pressure, not a pulmonary artery pressure. And then the balloon port, which is red, so that you know not to inject saline in there and burst the balloon, is right here. It will come with a syringe. Not all syringes are locked to the max, which is 3 cc's of air. It also has this latch here so that right now it is in the locked position, and if you align these red lines, it would be in the open position. So you know if the balloon is staying inflated or if you need to deflate the balloon to move the catheter. And again, of course, that does connect to the balloon. Now, the thermistor you will hear about is a component of the Swan balloon. The thermistor itself is not a port, and the thermistor is located about 4 to 6 centimeters proximal, so before the distal end of the catheter. And that's important because this is what is doing all of the work when you are injecting that saline and it's measuring the time it takes to get from point A to point B. Now, what are some of the things that can happen? A lot actually has to do with the balloon. So the balloon has what I guess you could call a suggested pressure or a nominal volume of 0.5 to actually 1.5 milliliters or cc's of volume. So what you are doing is you're using air and you're filling the balloon with air. Burst is at 3. So that means you don't want to do that because the balloon can burst. So when you're prepping this, you're going to prep it outside of the body and you're going to check the integrity of the balloon under saline. If it bubbles up when you inject some of that air, then you know it has a leak and you need to change it out. If it doesn't inflate at all, then it's already busted. And again, you want to change that out. Now, when you are in the body, you can overinflate the balloon and you can rupture the balloon, which means all of that air that was in the balloon now comes out, right? And that becomes an air embolus. Or you could cause a pulmonary artery rupture, which is much worse. So that means you over wedge the balloon. You push it so far into a distal PA branch or a smaller branch, you inflate the balloon bursts that vessel. And that's very bad because it's very difficult for us to tamponade in that area to stop the bleeding, and that can progress very quickly. So this is why the rule for inflating the balloon isn't just automatically go up to 0.5 or 1, even though that's to 1.5 because that's suggested. You really want to inflate until you see your PA pressure turn into a wedge pressure. If you meet that pressure already at 0.5, then there's no need to go all the way up to 1.5 because you might be in a smaller area or the vessel might be smaller than you anticipated and you don't want to risk this. So just do enough that's appropriate to get that wedge pressure in there. Under inflation. So what if I wedged it all the way up there and I'm moving it around, kept it at 0.3 or just didn't inflate at all? Then what you're doing is you're causing that at the point of the balloon is to leave an atraumatic tip so it can kind of move around without injury. Now, if you deflate it, you just have a catheter. Sometimes we're floating it up there without a wire. That's one thing about right heart caths. They're not all over the wire. And you can cause vascular injury or even endocardial injury if you're like in the right atrium, right ventricle. So we like to inflate the balloon also for placement to kind of float it up into place. For the order in which the procedure goes, you can get pressures on the way in or on the way out. Some physicians prefer one way or the other, but sometimes if it's very easy to float, we automatically get into the PA. We might get pressures on the way out, and we're going to take advantage of the fact that it went up into the area we wanted it to. Sometimes we might not be able to wedge at all. That could be, or not even get a good occlusive pressure. It could be because there's a lot of regurg going on in the valves, we can't get into position. It might be because there's some dilation in the pulmonary artery, so we can't get to a branch kind of small enough to get that occlusive pressure, and that's okay. Sometimes you can, sometimes you can't. You don't want to force it. Now, how the thermodilution injection works. Remember, we talked about we're injecting in that blue port, right, in the blue injectate port, and we're injecting about 10 cc's from our syringe. When we inject it there, it comes out here in the right atrium. And what it's doing is you injected that saline here, it's going to travel, right, with the normal flow of blood and go out to the lungs. And that thermistor is going to pick up that change in temperature. Remember, it's a temperature probe. So what it is measuring is the time that it takes from when you inject all of that saline goes here, right, that you had at this cooler temperature outside of the body. And you have the thermistor, the temperature probe, over here. So this cooler fluid is going to travel from here, point A, up to point B. And that thermistor is going to go, hey, that's a little cooler than the normal body temperature we are at. So we go, oh, and then we see how long it takes for that to return back to the normal temperature of the body. And that's how long it took for the rest of the blood to kind of move past this and, quote, wash out that cooler saline. Thank you so much for tuning in. I hope that helps. We are going to next kind of go into a left heart cath, the access, how that works, some of the things that we are looking at that you want to pay attention to, including left ventricular and aortic pressures. But if you have any questions, please comment them below and make sure you hit that subscribe button.